All right, we have a 45-year-old female presents with a complaint of pain and infection. Would you agree with me that this is a high-risk patient? You see the fistula, you see the inflamed tissue, and you see that tooth that is displaced labially. The patient does not want removable prosthesis, is very concerned about aesthetics, and the restorative dentist says, Dr. Moy, go ahead and do what you want to do. I'm ready to do anything for this patient, whether it's going to be putting a crown on the implant, putting a provisional removable prosthesis, or what have you. So, we all want to see x-rays, okay? So this is the x-ray. And if you really want to see it in high definition, here is the tooth. Now, what is surprising here is that with that fistula, the labial plate appears intact. That's a good sign, right? But what should we be looking at if we're thinking of extraction and immediate implant placement? What should we be looking at? All of you got it correct. That's right, the palatal vault, or the palatal cortical bone, because this is where we're going to gain stability with that immediately placed implant, okay? So all of you get a free unit. So we remove the tooth. We use our surgical template to place our implants, and we take our initial ISQ measurement of 73/78. So the question here, do you graft the voids around the implant and bury it for a healing period? Or do you place a healing abutment onto the implant and provisionalize with a removable prosthesis? Do you immediately load the implant with a provisional fixed crown and keeping the crown in infra-occlusion, out of occlusion? Or do you immediately load this implant with a definitive crown as soon as possible? A, B, C, or D? Now, the reason why we're asking this is because this is everyday clinical decision making that you have to do if you're placing implants, and if your patient is demanding a fixed type of restoration. And so based on the surgery, based on the ISQ value, what would you do? How would you treat this patient? It will be interesting to see what your colleagues say. Oh, 65% of you say bury the implant, right? No. It says immediate load this implant with a provisional fixed crown and keeping the crown in infra-occlusion. Oh, here comes some outliers. All right, we're still ahead though, huh? And that is absolutely right. Now, why did 65% of you pick that choice? Because I didn't tell you what insertion torque value was, did I? I only showed you the ISQ measurement. And so this tells me that many of you in the audience have experience with Osstell or are using it simply for this decision-making choice. So, that is exactly what I did. I agree with 65% of you. The others, I'm not so sure. But this is what we did. 10 days, status post immediate provisionalization, and after a healing period, you can see the transition. Now, the next question. How long do you wait with that ISQ value? Remember what it was? Okay, do you wait 2 months, 4 months, 6 months, or 8 months? Knowing the clinical condition that you were treating when you first took the tooth out. 2 months. Oh, some of you are changing your mind. That's not fair. Got to stick with your decision. Ah, okay, here we go. 2 months, 4 months. The majority of you say between 2 to 4 months. I waited 6 months. Why? The reason why I waited 6 months is there is no reason to jump in there sooner than later at this point in time. The patient has what she wanted, a fixed restoration, fairly natural looking. Yes, it's discolored, but why would you want to go in there sooner than later in a difficult situation like this, in a very high-risk patient? So don't just rely on pure ISQ values or anything else that you rely on to make those decisions. Look at what the patient is dealing with. The other reason for waiting 6 months is really to let that soft tissue mature. Because as Marcus has informed you, it's ideal to have a provisional restoration with the ideal emergence contours to help develop this healing soft tissue. Now, at 6 months, we remove that crown, and you can see, again, the maturation of the soft tissue. We have a little bit of cement exuding out from underneath that crown. So this is the real main reason why I prefer to go with a screw retain provisional restoration rather than cement retain. But you can obviously see the health of the tissue as well as the papilla maintenance around those natural teeth. And now at 6 months, the ISQ value is 84. Now, what does that tell you? You've gone from a 73, 78 to an 84. It tells us that we've reached biologic maturity, right? We have achieved now biologic stability and have transitioned out of the mechanical. So now you can do whatever you like with that implant because it's stable and it's going to hold up. And there we have it at 3 years follow-up. So, Marcus mentioned about micromobility, and this is the main difference between the use of the resonance frequency analysis compared to insertion torque, amongst many other things. Because insertion torque does not give you a measurement of micromobility. It only gives you the frictional resistance that you get when you're turning that implant in. And I've already given you an example of how you can achieve high frictional resistance, right? You just under-prepare the implant site and you'll get great insertion torque. But that will not tell you the ability for that implant to heal, or rather the bone to respond to that force. So what this tells me is that going from 73 to 84, we have reduced the micromobility of that implant to almost 0.